Our next topic, which is leveraging technology and pharmacy services for optimizing patient experience and safety. And we have Mohd Hisham, Mr. Mohd Hisham, who's a lead clinical pharmacist from Cleveland Clinic, Abu Dhabi. Can I have a round of applause for him? He's the lead clinical pharmacist at Cleveland Clinics, Abu Dhabi, clinical assistant professor, Department of Medicine, Cleveland Clinics, learner, College of Medicine, Case Western Reserve University, Cleveland, Ohio, USA, and so forth. There's a lot to say, but we are short of time, and I would request Mr. Hisham to please start his session. Thank you.
Very good morning to everybody. Thank you so much for the invite to Mrs. Bobby Ramesh and the administration from Sarvodaya. It's a fantastic conference, and I'm here to fascinate you about the world of technology and how pharmacy services will help in optimizing the patient safety and patient experience. So before we start, I do not have any disclosures. Most of the images shown on this presentation are something similar to what we have in our hospital, but it's not the images are from Google, but it's not the exact ones we have from the hospital system. It's just because of institutional restrictions, I'll have to show images which is outside of the ones we use. The learning objectives, we'll see how technology and pharmacy optimizes patient safety, various pharmacy services to improve patient experience and safety as well. So this is a very normal, very regular, routine medication journey, which happens. Physician has a physician, nurse, pharmacist involved, and again, this team communicates between them to optimize patient care. Sometimes the physician orders, the nurse administers, have any clarification, go back to physician, checks, and again from the pharmacy they dispense medications, they speak with the physician or the nurses on anything different. So what I'm going to show you is how technology improves all of these communication and keeping patient in the center to improve their safety and experience. That is the most important thing. Sometimes these could be through systems like electronic medical records, or most of the time it's through paper. But the most important thing in our presentation is the medication journey from the time it comes to the hospital to the time the patient leaves the hospital. So I'm not talking about the patient coming to the hospital, I'm talking about procuring medications to the hospital and medications leaving the hospital through discharge, how technology helps in all of these. So just starting off, I'm just showing you something which is called a carousel. It is which is used for inventory management basically. So it's like a system where you can see it has like 22 rows of shelves, and again it has like 10 columns where each column would have three departments in there, and again each of these like would carry medications. And what if the supply chain, say your stock in the whole hospital or throughout the hospital at different spaces is say 100, and again at each par levels the medication gets automatically ordered. The system does that for you, and you don't need to indent, or you just have to set par levels, max par, minimum par, what should be in emergency department, what should be there in the OR, or what should be there in the ICU, what should be there on cardiac floor. Again, what comes for us from outside, from the supplier, how much should be there in the pharmacy, how much should be stocked in the supply chain. So again, what if a system does that for you? And again, when it's done by a system, it has to be done appropriately, where each space there is always an opportunity for scanning, and the right medications are barcoded and put inside the right bins and goes to the right patient. I'm going to talk something which is unique and which is really good, which is barcoded medication administration, BCMA technology, where you scan for the right patient, you check with them their name, the full name, the details, the date of birth, and you scan the medication you administer. So there a lot of safety factors, the possibilities of medication error is very less. How does that happen is you have to have barcoded medication, which I'll come to in the subsequent slides. Again, you need a system where which allows you on the computer, it allows you should have a scanner. In that scanner, when you scan when pulling the medication or while administering it for the patient, all these helps in reducing the possibilities of error. The system does the double check for you, and you are the person who does the primary check by looking at the medication and all those things. So there you're trying to, the percentage of error comes down quite a lot if you adhere to the BCMA. And again, best hospitals would have 98 to 99 percentage of scanning, that is appropriate scanning without any overrides. Overrides means without administering the medication without scanning. So that could be done, say, in case of any emergencies, or like a patient is coding, or any rapid sequence intubation and things like that. Those instances, yeah, you could give that 1%, where you have independent people double checking at the point of care. But apart from that, all the regular medications, say if a hospital acquires 90 to 99 percentage of barcode medication administration, that itself reduces quite a lot of medication errors. So I've just mentioned barcode and medication. How is it done? So you can see this, all the medications, unit dosing. So why it's important, it's not only having technology, you save, it may be an investment, maybe a one-time investment, but a lot of revenue and outcome, a pharmacy, a lot of wastage is reduced, multiple things are there. On the long run, the hospital and the patient is benefited. So if you look at this, these are medications deblistered or cut into unit doses, barcoded. They have their unique batch number. The expiry date is modified because it was deblistered according to standards, and you put that. So this is unit dosing. Again, these are tablets. You can do you do the same for the vials. You do the same for the injections, the one-time use or the bulk items. Again, you also do for the syrups. You don't dispense it as a whole bottle. Instead, you do it in cups like that. So these are the machineries which help us do the barcoding. So again, you can see the one with the cups right over here. In the middle, this one is a fluid dose, which helps you unit dose medication, the syrups and all, based on the density, viscosity, the volume to be filled in the cups, along with you put based on the standard, you improve the expiry date and adjust it accordingly. Again, tablets, you deblister them. Some of them you don't deblister, you put that in the blister capsule itself and generate barcodes. These medications, barcoded ones, are stocked into the carousel, which I showed you in the first slide, and based on the floor needs, you stock it on the floor. So on the floor, when a nurse pulls it out from the cabinets, the patient is charged accordingly. You avoid a lot of things which I will explain. So I told you these medications are stocked in the pharmacy and on the floors as well. So in the pharmacy, on the carousel which I showed you, the power levels, say for example in the cardiology floor, aspirin 100 milligrams, you set the maximum power for the cabinet is 50, the minimum power is 10. So when it touches 10, the integration of technology is such a way that it gives a message to pharmacy that there is only 10 more in this cabinet, you can load more. And again, that what happens over here is these are automated cabinets which are used. It's again a computer. Through electronic medical records, these go into the system. The nurse logs in with biometrics, fingerprints or password. They open and you see these are the patients assigned to me. Click on the patient, you would see aspirin 100 milligrams due at 9 a.m. You click on that. These medications, you have a lot of drawers over here, you have shelves over there. They open, the nurse scans the shelf to make sure that they scan the right shelf. When they pull out the medication, they scan the medication to make sure the right medication, and they close the QB, they sign out the computer, go to the patient, check with the patient what is your full name, what is your date of birth, and scan the tag on the patient, scans the medication and gives that. So there's a lot of safety things over here, and because these medications are already on the floor, it's you're not delaying any patient care at all. Patient experience improves because patient in pain, you don't want to wait for the pharmacy to send these medications. And again, it's all available on the floor. You don't have to even worry about indenting the medication on the floor, because on administration or when you pull out the devices, it's such a way that it's already patient is charged for that and you don't have to worry about that. These are how when the QB opens, you'll find these many drawers, racks and all barcoded. You scan them, as I've already mentioned. You can customize this based on the space you have and medication you put, and based on the power levels, because again you have to customize it based on the floor, making sure that most of the medication are pulled out from the floor based on the need of the floor. Maybe a cardiology floor, the need of medications and the medication will be completely different from that of stroke floor or another surgical floor. So things like that. Again, ICU need to be fully optimized because you don't want to delay patient care at any point, and these are few things which are very important. So I told you about electronic medical records. So this is just a computerized physician order entry. So I'm just showing you an example. So here is a system where it allows you to put in the right medication, right doses, the frequency, and the specific indications or administration. It's just one tablet. Same goes for if you apply for inotropes or any IV medications, antibiotics and all. Everything would have a proper admin instructions and all those details in there. So why this is important is just because possibilities of error are there, interpretation is there, and the system it goes in, it helps you optimize patient care and safety as well. Few things how you could further optimize this is like building it and being more creative and innovative, where you kind of put order sets or again puts sets protocols or policies in such a way that it does not have to depend on a physician. A nurse-driven protocol. Say, for example, in the ICU, we have electrolyte replacement protocols driven by the nurses. The nurse does not have to call the physician and ask, can I replace this much? No. Say, for example, if you put electrolyte replacement protocol, you type that in the order set. It comes, you get potassium replacement. Patient has central line or peripheral line. Potassium is 3.4 to 3.6. Replace 20 millimoles. If it's a peripheral line, you do it in 250. If it's a central line, do it in 100 ml. Potassium is 3.2 to 3.4. Do 40 millimoles. Dilution changes based on central line. Likewise for phosphate, for calcium, for magnesium. So these are there which comes up and it's nurse driven. Same goes for heparin or insulin or any of these things. Again, for inotropes and all, the physicians makes it easier for the physicians to order based on titration parameters for the nurses, and it's always linked to a protocol which makes it a lot easier. So if the same thing if the patient's going home, getting discharged, the same thing applies as well. So say for example, our waiting time in the outpatient pharmacy is 10 to 15 minutes maximum or even less than that. Why? The physician prescribes the medication on in his OP itself. The medication gets approved, insurance wise it gets approved and it's get ready in the pharmacy. So there's no delay. The patient comes from the OP to the pharmacy, medication is ready. They just have to take a token, wait for it to be double checked, scanned and given to the patient. So these are few things which how integration of these technology would help. Again, integration along with, say, we're not talking about just medication. This is linked to the lab. This is linked to imaging. This is linked to ECGs or the complete lab results, echo or like patient images or notes, physician notes, all the allied health notes, everything in one space. It includes, again, it gets also integrated to the health system in the other hospitals. I can exactly see what the other hospital patient, what care of patient received. But it's all integrated in such a way that in one system, you open everything and it's already there. That makes it a lot easier to optimize patient care. So how does that optimize patient experience? Again, less time. So as you can see, these less time to dispensing administration, patient in pain or anything emergency, you don't have to wait for any of these. Again, availability is already available on the floor, it's customized. Medication safety point of view, again, you minimize any disruptions or delays or risks. You save nursing time, you save pharmacy time. So multiple things are saved. Again, the workflow is more efficient and enhanced. And you, with the IT team, you leverage to optimize this care rather than just working on the same things. And again, it's a lot of infrastructure and IT support you need for this. But it is one-time investment, but it's going to be definitely useful for the patient experience and care. If you look at sterile preparation, there you go. These are all sterile rooms where you could, again, a lot of bloodstream infection happens in the hospital. KPIs for different accreditation and for the hospital as such. But if you prepare this in a very sterile way, so it's not like bedside preparation, prepare it in a sterile way. It's just one room invested, and in this room you follow the proper USP 797 guidelines, how to prepare proper pressure rooms and all. And these medication, it could be the beyond use date can go up to 7 days as well when refrigerated. And you could batch, you save time, you save revenue in terms like you could use multi-vials and like different doses. It's revenue for the hospital, revenue for the, again, nursing time saved and multiple things like that. So these are just, again, TPNs could be compounded based on the patient needs. So this is something which I've just mentioned for standards for sterile room preparation. Again, if potassium 20 millimoles is quite a daily usage in your hospital, that could be batched, and a shelf life of 7 days could be put. Again, piperacillin tazobactam is a common antibiotic which is used. It has a stability of 7 days if it's prepared properly in sterile techniques based on these standards. So depending upon that, you could customize and modify. Use of smart pumps. So use of smart pumps, these are like very simple, very user-friendly ones. You put the patient details, height, weight, and again, what you first click on what medication it is, enter these details. The pump itself will calculate based on the settings in there. Again, there is no possibilities of it. It's just a dual sign-off needed. And I think that should be the most important thing. Again, double check and sign off is quite important over there, and you kind of clear that. So once you have a system in place, you have people trained in that, and you already have optimized technology, now you encourage a culture of reporting, something which I've discussed yesterday. This is a system where it helps people report. It does not have to be only medication errors. It could be anything related to clinical or non-clinical or things like that. So this is a system where risk management events reporting happens, and again, this on a daily basis you run this report and keep a track of how you could improve, and all these are keeping patient centered. You make sure that proper action plan is taken. Ownership. So if it's a medication error or thing, pharmacy takes ownership. You don't point fingers on the nurses and say that the nurse has done the mistake, it's the individual problem. No. What did you do? What did the pharmacy do to put protocols, to put policies, procedures in place? How did you train those nurses? Were the nurse aware of it? Things like that. And then if there's a thing, the system has to change, then you have to implement these things. Then you come and then you set these things. So these are few things which are very important when technology is leveraged to help. So quickly, I just have a few seconds, but I'll just wind up in 2-3 minutes. How clinical pharmacy patient-centered. So it's just, I'm not going to all in detail, I'll show you data of how patient-centered care optimizes. This is a clinical pharmacist role, different roles in which clinical pharmacists could work. Like mostly it's dosing, hepatic, renal, dialysis, CRRT, or ECMO dosing, or again, it also depends upon special population, pediatric, pregnancy, elderly. So apart from that, medication reconciliation, transition, these are most important aspects. So why, whenever a clinical pharmacist, it's as an advocate for clinical pharmacy, when you have a person going to the administration asking, can I have clinical pharmacist, can I start as a clinical pharmacist? The problem is, the question which comes very common in India is what value it adds. Like, okay, I'm paying a physician, he gets me consults, patient come to see. I'm paying nursing, the nurses come and see the patient go. What does clinical pharmacy services add? So that value, how it's added, is what I'm going to show. Keeping the patient centered. It's not one size fits all for each patient. So you're optimizing patient care, improving the quality through clinical pharmacy services. And I think that's the most important thing over here, and by keeping patient centered. So just quickly, a few publications which I've been a part of. I'm just not going to talk of data which comes from US or outside, but we being a part of these publications, and this is definitely doable in India. Simple example, transition of care led by pharmacist. Simple example is admission medication reconciliation properly done by a pharmacist. You clinically review indications, all the indication needs and all, put that properly in. On discharge, you make sure that all medication has a justified indication, if it's optimized or not, and all those details come in over there. So this has improved, reduced the readmissions, improved the length of stay, a lot of cost savings have been there. So it's an impactful thing which definitely pharmacists can do, a basic thing which could be implemented in the hospital. So most of them get involved in audits, but think about a the better picture for the hospital in terms of length of stay, readmissions and all. This is mostly done in medical and cardiac units. This is another one where, again, weekend is something which is missed. Less consultants, less senior staffs, nursing staffs and things like that. So where you implement clinical pharmacy services on a weekend, this is something which improved antimicrobial stewardship on a weekend. We also have floor coverage for clinical pharmacy, admission medrec and discharge medrec on weekends. This is something which we implemented in the ED, urine culture review, where it's done by the pharmacist, and this helps save physician time, appropriateness of antibiotic, you unnecessarily avoid antibiotics in asymptomatic bacteria, things like that. The allergy testings for antibiotic, again, assessment done by the pharmacist to remove and delabel unnecessary or false allergies. Again, this is protocol wise, where I'm just showing you examples where pharmacist plays a very important role in optimizing how these protocols help. Is like one of the speakers shared yesterday, a heart failure patient. Are we meeting those parameters? A patient goes home, a heart failure patient has to be discharged on a ACE or ARB or ARNI or things like that. So again, are we looking at these? Because these help in optimization. There are a lot of studies which say readmission rates, mortality benefits, and all these are there with these medications. So these are some other protocols like nurse, the pharmacist-led screening for like anemia and iron replacement, where it's functional anemia for heart failure patients. You optimize ED by putting antibiotic order sets. Say a patient comes with pneumonia, they click on the pneumonia order set for ICU or ED. Again, in that community acquired pneumonia, it gives you an option for amoxicillin, clavulanic acid, azithromycin, like that. Again, antibiotics, when you put dose for present tazobactam, more than 40 EGFR, you adjust it, the full dose goes on. 20 to 40, it's 3.375. Less than 20, it's 2.25. So things like that, the system does that for you. You don't have to be on there. So these are a few examples. If you talk, all these are from Middle East. I have something from India. So this is when I was a critical care pharmacist while in India. A lot of errors, a lot of quality improvement things. Most importantly, drug dilution compatibilities. These are also published. The take-home message over here is technology automation improves patient safety and outcome. Patient-centric clinical pharmacy helps to improve the quality, publish the data. You need to show the outcome in terms of not only monitoring patient experience and things like that. Like simple example is discharge. When your patient goes out of the pharmacy within 10 minutes itself is an achievement. So that is what I have for here. Thank you so much.
Wow, so much of technology already available, but in India, if we talk about, so I think we are taking steps towards that intersection of pharmacy and technology. But that was a lovely session. I think all of us would be taking some clues, some pointers, some facts with us to our own setups, and will be definitely incorporating in our own ways. I would like to request you to the stage and felicitate Mohd Hisham. Please come. Thank you.